What else? Issues of trust, trust in terms of the community, in terms of who's doing the analysis. I had a gentleman in the boot camp this weekend said, do you think they're just testing us to make more money and they're really not doing, you know what I'm saying? You do the diagnosis. So could be false. So there are a variety of reasons people don't. And so the other thing that you know, Diane, I'm sorry.
You say lack of knowledge because sometimes if the primary care diagnosed you, they just leave it at that. They don't know to go to a neurologist to get further information.
And let me repeat what you said in case somebody didn't hear it. Lack of knowledge. Because sometimes we go to our primary care doctors, and our primary care doctor doesn't necessarily make the referral, and we don't know that don't have to have referrals sometimes from our primary care doctors. Check your insurance, and you can make the direct connect yourself. So we talked about shame, we talked about cost, we talked about availability. Did you know that dementia is 2 to 3 times higher and more prevalent in our community than others? And it's so important to get an early diagnosis because what medications they have that have been stated as being effective. We did that last session on the medications and which ones work and don't work and which studies we were involved in and we weren't involved in or not. Kind of say that depending on the stage, meaning the early stages, the medications are known to work a little better than the later stages. If we're the last ones getting the assessments, sometimes whatever medication is out there may not work because of the stage that our loved one is in. So what I wanted to do is to bring a guest in today that we can get some real information about dementia, what is dementia, as well as how do they diagnose it. So many of you have said to me, I went to the doctor and he said he has dementia. And she said, I knew that before I went to the doctor. And I said, well, what else did they say? Nothing. So you need to think about what questions you should be asking, what information should you walk out of the room with, what persons that you will connect with moving forward. And so with that, I have a talent in the room. Our new meeting, Dr. Popli, I hope I pronounced it correctly, and he is currently a clinical assistant professor at the University of Michigan, Department of Neurology. If you don't get him, let's get some of the best folks to come in here and share information. Let's do a welcome to our speaker. He not only does diagnosis, meaning he could work, he could assess me if I went to him and had the right insurance. But also, he does research. Because not only do you want to be diagnosed, you like to think somebody's working on a cure. And the research would help us better understand what to anticipate. My only piece of advice on research is this is one of my pet peeves. Too often we do research on communities and we don't give them any information about the results. I encourage everyone who comes to me, can you give me access to basically black folks, because that's what they're asking for. I said, what part of your budget has been identified as follow-up dollars? To come back to this community and say, this is what we learned, this is how you apply it. So with that as my little pet peeve, forgive me, let's welcome. Thankful for the gifts that we're going to get today. Welcome.
Thank you so much, Paula. Thank you. Thank you so much, Paula, for that kind introduction. And I agree. Having that knowledge, people who take part in research and understanding what that means for a person, for a community, is really important. I'm glad that we can kind of focus on that. Yeah. Here, we can help out here. So let's go to the other PowerPoint. I opened it up earlier. Yep, the third one there. Yeah, and then if we hit this button here, there we go, and that should do it. Okay. Hopefully you can all see this, but I'll be talking through everything. So, so like Paula mentioned, my name's Dr. Popli. I work at the University of Michigan. I'm a dementia specialist, so I trained in internal medicine, then I trained in neurology, and then I did training in dementia and neurodegenerative disease. And I see patients both at the University of Michigan and at the VA in Ann Arbor. So I see people coming from all over the state of Michigan, even some of our neighboring states in Indiana and Ohio, especially through that VA system. So today I wanted to kind of walk through a couple different goals. And the first goal is to make sure we're all speaking the same language and talk a little bit about how I define dementia and other kind of terms we use in the dementia space, and make sure we're using those words the same way. I think there's been a lot of changes in terms of how we as a society and as physicians or doctors or medical providers have come to understand what we mean by the term dementia. And I think people come from different perspectives on that, so I want to make sure we're all speaking the same language there. The number two thing we're going to do is we're going to walk through kind of the assessment. When people come into my clinic, what am I doing? What am I looking for? What are the things that, so we can better understand why are we asking these questions, what kind of questions are important to me, and for what purpose. And then the third part, I'm going to talk about some of the extra tests that we do beyond that initial clinic visit, particularly focusing on some of the blood tests and maybe some of even the newer blood tests that some of you may have heard about in the news recently, and also types of brain scans that we use that can help us put together the pieces of the puzzle that are dementia. Thank you. So the first message I tend to give for any talk I'm giving about diagnosing dementia is that it's complex, it's uncertain. Those things are really uncomfortable, right? We don't like uncertainty. We don't like to know, well, we don't know for sure, right? And that can be really tough. I know it's tough for me as a doctor, and I can only imagine how tough it might be for a patient who's going through that, or for a caregiver to say, we're not getting a clear answer, right? That can be a big sense of frustration. But we're going to talk about, why there might be some uncertainty within that diagnosis and why it might be so complicated, the stuff that's underneath the hood. So I mentioned that first goal, right? We're going to do some definitions about what I mean when I use that term dementia. And we can do the next slide, please. Perfect. So when I think of that word dementia, I'm thinking of a descriptive term that applies when people meet two conditions. And the first condition is that they have to have changes in their thinking, memory, language, behavior, right? So there should be a new change in their thinking skills, right? And that's the thing we all think about when we think about dementia, that someone has a change in their memory or a change in how they're able to move through the world. The second condition is that those changes have to affect their ability to live independently, to do the things we all do day to day and maybe take for granted, or that we don't think about, how complicated this is to do, to say, okay, I'm going to go to the bank and handle this account, or, call the pharmacy and get these prescriptions in because I'm running low and I need this many more for this many days. So you have to have thinking skill changes, and then those have to affect those day-to-day tasks. So the word dementia it's really more of a description. It's more of an umbrella term that applies to this status. Thinking changes that affect your day-to-day independence. That's separate from the causes of dementia, of which there are dozens, if not hundreds of things. And I just listed a few categories up there, and we'll get a little bit more into that in a few slides. So dementia exists on this spectrum with what we think of as maybe typical thinking skills or more age-related thinking skill changes, because we all know that our thinking skills do change as we get older, and we've started to understand that some of those changes are more expected or more typical, and there's some that go beyond that, where we start to worry more about dementia. And we can go forward. Perfect. So if we look at someone on the green side of that arrow, that maybe normal thinking skills for their age, and we look at their daily function, and they're functioning, they're getting around, they're doing the things they need to do day to day, week to week. And we go to the next, please. Then we might say that's normal cognition or age-related thinking. So that's our umbrella term, right? Age-related cognitive change. If we look at the red side, we say, okay, someone who has thinking skills that are not meeting those marks for what we might expect for their age, and they are unable to function independently, right? Those are our two criteria for dementia, right? It's also referred to as major neurocognitive disorder. If you talk to a psychologist or a neuropsychologist, they tend to use that terminology. There's a spectrum here. There's an in-between, right? Where people might have changes in their thinking skills, but they're still handling their day-to-day activities independently. And that's the kind of middle section there, and we refer to that as mild cognitive impairment. So these are kind of the spectrum of umbrella terms that can describe the kind of severity of the thinking skill changes, and it kind of hinges on their ability to do day-to-day activities. I want to talk a little bit more about the different types of thinking skill changes that we might see along the spectrum. So I like to use this hexagon, and this is what I teach my residents and my trainees. Different types of thinking skills, different types of circuits in the brain that can be affected when we're seeing mild cognitive impairment or we're seeing dementia. And so there's, a big one that I think we all think of. What type of thinking skill comes to mind when you're thinking of someone with dementia? What type of problem? Memory. So memory is a big one that we all think of. But memory is not the only type of thinking skill that can be affected in the brain when we're seeing someone with dementia or cognitive impairment. There are other thinking skills such as attention skills, focus, concentration skills, executive function, which is a big broad category that tells us about complex problem solving and judgment and planning and multiple step problem solving. There could also be visuospatial skills, which is how our brain perceives, makes use of the information from our eyes, right? Shape and space and orientation and recognition. And then also language skills, which is part of what my research focuses on, right? Trouble with using words, understanding words, trouble with speech, right? These are things we see as different parts of the brain become affected. The next one is another big broad category that I refer to as behavior, right? And I think sometimes these are under-recognized changes in the brain that can lead to these problems in cognitive impairment and dementia, where people can have significant mood problems. They can become really anxious, very depressed. They can have changes in personality, where they do things that are really out of character, not really appropriate to the situation that they're in. They could have problems like hallucinations or delusions, where they have these really fixed, strong beliefs about things that are not true. And these are changes that we can see from those changes in the brain. And then the last part of our hexagon, it's not really a thinking skill, but it is something that I look for very importantly when people are coming to see me, and that's motor skills, right? How the brain controls our muscles, muscle coordination, muscle strength, how it helps us to walk and move, and those are parts of the brain that could also be affected by some of these similar conditions. Okay. And importantly, different people with dementia are not all going to look the same at the beginning, at the middle, or at the end, right? They might have issues with memory as they start, but then some of those other parts of our hexagon, those other domains, might become affected as they progress through the disease. But someone else might come in and have a lot of changes with behavior as they start, and maybe never have too much problem with memory. So we do see that these changes in the brain spread over time as the disease progresses. And then a quick 2 slides on the types of functioning skills we look for. So I'm sure many of you are familiar with how we categorize these types of daily functioning. We have a list of the very basic day-to-day things we all do, right? Mobility, using the restroom, hygiene, feeding ourselves, getting up, getting out of bed. And we call those the basic activities of daily living, or ADLs. And then on the right side of the screen, we've got the more complicated things we all do on a day-to-day or week-to-week basis that we all learn how to do to become basically a functioning adult in our society, right? Transporting ourselves, handling our finances, handling our housework, shopping, groceries, cooking, all of these things that are a bit more complicated. Now, those are called instrumental activities of daily living, or IADLs. And those are usually some of the first things that might start to have problems when people are having cognitive impairment or signs of dementia. And in particular, there's 3 of them that I always ask about because they're really, really important, and they can be some of the earliest signs because of how common they are, but also because of how much of a safety risk they might pose. So things like driving. Are we seeing changes in ability to navigate, to understand the rules of the road, to pay attention to what's going on around you when you're driving, to solve problems really quickly when you're behind the wheel, right? That's really important. I worry about those things a lot for many of my patients. Managing finances, right? We don't want to be missing out on bills or double paying, or we want to make sure that those things are in order and they're organized in a good way. And medications are a big change that we want to keep a close eye on, especially in those early stages, as obviously some medications are important to be taking daily, but we also don't want people overdosing or taking medications more than once because they couldn't remember that they took them, or because of some other change in their thinking skills. So those 3 I'm always asking about, and they tend to be some of the earliest changes, but we do see changes in these other types of functional skills, and that's how we define that dementia term, right? That they're having trouble doing those independently. All right, so now should be all on the same page when it comes to when I use that word dementia, what do I mean, right? A description. Right? It does not tell me what is causing the dementia. And so the first question I'm asking when people are coming in to see me is, do they have dementia, right? And sometimes that's very obvious, as Paula mentioned, that I know they have dementia because walking in, I know that they have thinking changes, and I know they're having trouble managing their day-to-day life. But this is the bigger question that I'm trying to answer, is what is causing the dementia? What types of things do we have to be looking out for that we can change or modify or adapt to help keep this person safe, to keep them supported? So the answer to what causes dementia is so many things, right? All of these boxes are categories, and they're not even discrete diseases. They're categories of things that I'm thinking about that could play a role in brain function and in dementia. And so many of us think of dementia and we think of neurodegenerative diseases, right? Things like Alzheimer's disease. And that's a very large, very important cause of dementia, particularly in older populations. But it's not the only cause, right? So apart from neurodegeneration, which I have in the bottom right corner there, we've got other medical illnesses, things like liver disease, kidney disease. We've got psychiatric illnesses, traumatic brain injuries. We've got metabolic problems, vitamin deficiencies, hormone problems. We've got infections, we've got stroke, we've got medications or drug use, alcohol, or certain toxic exposures. We've got autoimmune conditions, inflammatory conditions. We've got structural changes in the brain, things like brain tumors or bleeds or extra fluid in the brain. So these are all things that are rarer to cause dementia in certain populations, but they're still things we think about. Even within neurodegenerative disease, Alzheimer's disease is the most common neurodegenerative disease, but there are dozens of other types of neurodegenerative diseases that can look very similar or have some overlap. And part of what I do, what we do, is trying to figure out which of those might be in the mix. The other thing that makes this tricky, apart from the vast array of things that have to be on our mind, is that there's no rule saying that someone only has to have one thing, right? You could have strokes and you could have Alzheimer's disease. You could have a vitamin deficiency and you can have problems with profound depression, right? So in many cases, and this is kind of the next kind of take-home point on the next slide, most cases of dementia that I see, I can identify more than one thing that could be contributing to, right? There could be a primary thing. We see signs of Alzheimer's disease, and we know that that's a very important cause of what's going on, but we also see issues like very poor sleep, and we also see low vitamin B12, and we also see that your thyroid hormone is off, and we also see that, there's an alcohol use history, or any of those other categories that I mentioned. And so identifying that primary cause and what all those other kind of secondary contributing factors is again, part of what we're trying to do. All right. So moving on to the next section, I want to walk through what a visit with someone like me would look like and what kinds of things I'm looking for to try and answer those two questions, right? Does this person have dementia or mild cognitive impairment? And two, what are those contributing factors? What are those causes? Are we seeing signs of a neurodegenerative disease? Are we seeing signs of vascular or stroke-related problems? Are we seeing some of these other medical issues that could be helpful? So this visit kind of comes in 3 steps. The first step is the neurology visit. So coming in to see the neurologist, and we're going to talk through what the pieces of that are, but essentially getting a really good story about what kinds of changes we're seeing, and doing a very thorough exam to look at the connections between the brain and the spine and the nerves and the muscles. Because that can give us clues about what other changes might be happening in the brain. Beyond that, we might recommend further types of tests, again, which we'll talk about in a little more detail, certain blood tests to rule out some of these other issues or look for other medical problems, certain brain scans, or even more advanced testing depending on the situation. And then another important part of this process is having people come back to see us within a certain time span. Usually I give it somewhere between 4 to 6 months, especially because neurodegenerative diseases can progress slowly, and we want that time to see how are people doing? Is there anything we've changed that has helped them to stabilize or do better? Have they responded to those changes or treatments? Are we seeing that there's more changes or different problems that we need to be addressing? So that follow-up over time can be really important. Excellent. So the most important test when it comes to figuring out if someone has dementia and what the underlying cause of the dementia is that story. Is that history, and that's what I spend most of my time on. I do visits with patients, they take an hour, sometimes more, and the vast majority of that time is spent talking. It's talking about when did this start, how has it changed. Really important parts of this history obviously come from the patient, right? What are things that they've been experiencing, what are things that have been bothering them, but the vast majority of the time, the most important information I get is from the caregivers, is from the people who know the patient well, right? Who've been there to notice these things and provide this third-party, more objective view, in most cases, more objective view of what has been going on. In many cases of especially neurodegenerative disease, the ability of the person to understand the changes in their thinking skills, to understand time relationships, what's been going on with them, also is affected. And they might not necessarily be able to tell me what those changes are or how long, with a good amount of detail. And so we rely really heavily on people who have been there with the person and know what those changes look like. All right. Okay, so when we're going through that conversation, what are the questions I'm asking? What are things that would be important to know? So the first thing I already alluded to is timing. When did this start? How has it changed? This really helps us narrow down from all those different causes, those different boxes, right? Someone who was normal 3 months ago and now has trouble paying their bills and driving is a much different story than someone who had some milder changes 3 or 4 years ago and then very slowly changed over time, right? That gives me a lot of information about which boxes to pay more attention to and which to maybe take off our list. The next thing I'm looking for is the profile, the pattern, right? We think back to our hexagon. What are the types of thinking skill changes that have been affected? And the types of symptoms people have tend to reflect that, right? If people say, well, they're obviously having more issues with remembering conversations and details of what's happened to them, right? Then I'm really thinking about memory. But if people are having issues with, they're really having trouble organizing or planning, or if you give them multiple things to do and they have a little hard time figuring out and then I'm thinking about executive function. And those are different parts of the brain, and they can be affected by different processes preferentially. We're thinking about severity, right? Does this fall into mild cognitive impairment, dementia categories? So asking about those day-to-day activities and how well we've been able to adapt to some of those changes. And then that kind of leads into kind of the next big focus, which is on safety, right? Is the person safe in their situation? Are there resources? Are there changes, adaptations we can suggest or help make that would help keep that person safe? Now, apart from those kind of 4 main that pop up in that clinical history, in that initial conversation about the story of what's been happening. We also want to look at their prior medical history. Do they have, risk factors for other conditions? I mentioned the liver, cardiovascular disease, heart disease, any history of stroke or other problems like that could play a role. A big part of that medical history is what medications are they taking or have taken in the past, right? I mentioned that exposures to certain recreational substances or even prescription medications have been linked to risk for dementia as people get older. And so that's one thing that's really important. We also want to make sure that the medication someone is taking at that moment wouldn't be worsening or contributing to any cognitive changes that they're having at that time. Family history is a topic for discussion, right? People who have had someone in their family with dementia or Alzheimer's disease as a cause of dementia particularly are at an increased risk. They're at a little bit of increased risk to develop dementia. There are rare forms of dementia or neurodegenerative disease that can run in families. They can be passed on through the genes generation to generation. And so we want to make sure we're looking for that and screening for that and thinking about the person's risk in that regard. And then some of the other things that play a big role in our thinking skills. Sleep is one thing that I maybe mentioned offhand, but right, we're starting to understand more about how good quality, restful sleep impacts the risk for dementia and how it can change the brain function over time. Things like mood disorders, things like profound anxiety or depression can cause their own types of thinking skill changes, and they basically just make everything worse. And then things like vision loss or hearing loss, we're starting to understand more about how those play into the role of dementia risk as well, and how we can accommodate those and try to help people do better on a day-to-day basis. All right, so after the history, we move into the examination, right? So these are the two biggest areas of that neurologist evaluation. And the questions I'm trying to answer with the examination is, do I see signs of changes in those brain circuits, right? And I'm going to look at a couple different areas. We look at mental status and psychiatric status. And so this might include some quick tests of thinking skills, which I'll talk about a bit on the next slide. But looking at their behavior, their appearance, their mood, trying to test in a very basic way some of those different types of thinking skills like memory and problem solving and language tests. We're going to look at the nerves running to their face because that tells us a lot about the deep areas of the brain, right? The motor function, the sensory function, the coordination of those areas. We're going to look more broadly at the motor function. I mentioned that that's an area of the brain that can be affected by some of these conditions. So looking for signs of incoordination or slowness and stiffness that we can sometimes see in things like Parkinson's disease, which itself is a neurodegenerative condition and can lead to dementia. And so I look very closely for some of those things, looking at the sensory function and looking at walking and mobility, because that can tell us a lot about those connections between the brain, the spinal cord, and the nerves as they run out into our arms and legs. Very good. And so I brought up that cognitive testing or cognitive screening. And I think there's many people who are familiar or have had experience with the very brief kind of in-office cognitive testing type exams. And I use some of these in my practice and when I see patients. And there's a couple different things that these can be helpful for. They're not perfect tests, right? They're built to be to balance the kind of speed with also giving us useful information. There are psychologists, neuropsychologists who specialize in giving cognitive tests, and they do hour-long 2, 3, 4 hour-long evaluations, and that has its role, that has its place. But for many people, those can be very daunting, right? They can be kind of intimidating to go in and get your different thinking skills tested for 3 hours. And so sometimes these provide a better or more accessible option. So the kind of three big things I use this for, in primary care clinics, you might see primary care doctors using these types of bedside tests to try and screen for thinking skill changes, right? Someone says, well, I feel like I'm having more changes in my memory, and they might give you one of these tests to say, okay, where do you fall? Is it below a kind of set cutoff? And we say, okay, we're maybe more worried about this than we were before, or is it above? And maybe we're less worried about it. But these by themselves do not help us diagnose cognitive changes in and of themselves. I tend to use them a little bit differently, the second 2 points there. I use them to get a sense of that pattern. What's that profile? which of those points of the hexagon are being most affected, because they can help me test some of those problem solving, spatial skills, language skills, memory skills in a kind of brief way. And we can also use them to kind of track how people are doing over time. I mentioned that timing is really important, and sometimes we're not sure. Is someone getting worse over time? Are they kind of going up and down? Are they holding steady? And sometimes giving that same test to them after 3, 4, 5, 6, 7 months and saying, well, how do they do? Right? That can give us a nice graph of, well, where have things gone in the last few months? Okay, so the history, right, neurology history, the examination, using some of these in-office tests, right, that's where things start. But then we go beyond the exam room and we say, what are the other types of tests we can use to whittle down the different causes, right, all the different boxes that I listed before. And so this is a little checklist that I show the fellows, the geriatrics and neurology residents, that I say, these are the things that I'm thinking about sending tests for or sending referrals for when people come to see me. And we're going to talk about these in a little more detail, particularly the blood tests that are on the left side and the brain scans that are listed there with the little brain icon on the right. And I don't send all of these tests on everyone, right? Depends on the situation. But these are some of the things we're thinking about. And what I want to call to attention on this is referrals. I mentioned things like hearing impairment, vision impairment, mood problems, psychiatric problems, sleep problems, or financial, logistical, socio-legal issues that might be better handled by people with training in social work. So those I think are under-recognized, or starting to become more recognized pieces of how we take care of people with dementia, how we evaluate people with dementia, by building on all these even maybe smaller contributing factors, but contributing factors nonetheless. So let's talk about blood tests, because that I think will become an increasingly important part of what we do in this. But there's kind of two main reasons to do blood tests. So the first reason is we're going to, we can proceed to the next slide, I think. Yep, is we're going to check for reversible conditions. That's the number one reason that we're sending blood tests on people with dementia or cognitive impairment, right? I mentioned things like thyroid hormone. I mentioned things like certain vitamin levels like vitamin B12 or folic acid that are well known to cause problems in the brain cells or the nerve cells and lead to thinking skill changes. So everyone who comes in to see me, I make sure they get at least these 4 or 5 tests, right? A complete blood count to look for signs of inflammation, infection, or low blood cell counts that could herald anemia. A metabolic panel to look for the electrolyte levels, to look at their liver function, to look at their kidney function. I make sure they get a thyroid testing, right? Because having too low thyroid hormone or too high thyroid hormone can affect your thinking skills, and it's very treatable. I make sure they get vitamin B12 levels and folic acid levels, because I mentioned those are vitamins that are really important for how our brain cells use energy, and if they're not, if they are too low, then they can lead to those cognitive impairment or dementia presentations. Now, the second reason is, well, we might, based on someone's history or someone's pattern of their story, we might be looking for other conditions. Maybe they have a history of a certain autoimmune disease or certain risk factors for other issues. And so in some patients we'll be looking for things that apply to blood vessel health or heart health, right? Like blood glucose measurements, or what we call hemoglobin A1C, cholesterol screening. We might look for autoimmune disease markers. We might look for certain types of infections, particularly syphilis or HIV, which can cause a lot of problems in the body, but particularly a lot of problems in the brain. Or we might look for drug or toxic exposures, depending on certain the person's environment and where they've been and what kinds of activities they've been a part of. And then the third, and I find really exciting, is now we're developing more specific tests for neurodegenerative disease that are blood test based. And many of you may, and in particular these have focused on Alzheimer's disease as a neurodegenerative disease because it's so common, right? But amongst all those other neurodegenerative diseases, we're starting to develop better testing, and I'm very hopeful that we'll have blood tests for an array of neurodegenerative diseases, in the future. So many of you might have heard or seen the news of this, but a week or two, maybe 2 weeks ago, the FDA cleared the first blood test for Alzheimer's. They had given some, breakthrough designations and allowed labs to use these blood tests for the last few years, but this is the first fully approved blood test for Alzheimer's disease. And this blood test looks at the ratio of two proteins in the blood, and those proteins are associated with Alzheimer's disease. They're called tau protein and amyloid protein, and those might be familiar to you. We'll talk a little bit about them. The tau protein, the particular test, we call it phosphorylated or phospho-tau 217 or 217. And it's been shown to be much higher in patients who have underlying Alzheimer's disease protein changes in their brain, which we refer to as amyloid plaques or neurofibrillary tangles. And those plaques and tangles are made of these proteins. So the amyloid protein becomes the amyloid plaque, and the tau proteins become the tangles. And in the blood, if that phospho-tau 217 is high, it correlates really well with having plaques in the brain. And so in this study they took people with all different types of presentations of dementia, and they did a brain scan to look for amyloid plaques, which we'll talk about in a few slides. And they said, well, the people who had high levels of the phospho-tau 217 and had those amyloid plaques in their head, you could see that they fit into that Alzheimer's disease syndrome really well, that it differentiated them from these other types of neurodegenerative disease very well. And so we've started to use this in our clinic. I don't use this particular FDA cleared one just yet, but I do use the phospho-tau 217. And I think the next slide is, and mostly to use it as kind of help point our needle towards or away Alzheimer's disease. Someone comes in and they're having memory changes and they're the right age and the story fits, they've progressed the way we'd expect them to, and the profile on their testing looks very similar. Then I say, I'm worried about Alzheimer's disease, right? This test could help us to confirm that worry, or alternatively, if they show up and it's very normal, we say, well, maybe I was wrong. Maybe there's something else going on. We need to dig a little bit further, right? So by themselves, they might not, we don't know if by themselves they can predict if someone's going to get Alzheimer's disease or if they have Alzheimer's disease, but in the right context, in that story of someone who's having those thinking skill changes, then they can be really helpful to us. There's a lot of challenges to using these blood tests. They're still new. So like I said, they're not the be-all, end-all. We still don't know exactly how well they do in people who don't have cognitive changes, right? So someone who tests normally, they're functioning normally, if they have a high level on this, does that mean they have Alzheimer's? We don't know the answer to that. Does it mean they're going to get Alzheimer's? We don't know the answer to that. But we're working on it. That's part of the research work we're doing on tracking how these things might predict changes in the brain over time. One thing that we have to keep in mind is that these types of tests, as Paula mentioned, have not been well studied in non-white populations, particularly in Black Americans, Hispanic Americans. And there is some evidence to suggest that they're not as accurate in the Black population, that there's a higher number of false negatives, so that if you do the test, it comes back negative because the values seem to be lower. And we're not entirely sure why that is, not yet. It could have something to do with the type of measurement we're making. That 217 refers to a specific protein on the larger protein block, and it might be that a different form of the test might work better, but those are things that are being looked into, but would definitely need more support and more push and more information over time. So there are things we need, and apart from that, we know that other medical conditions like kidney problems, certain levels of vitamins like biotin can falsely change the levels of this test. So by themselves, yes. Good question. I don't know. The fact that they were just the question was, are they covered by insurance? So the fact that they were just approved by the FDA would suggest that this test would be covered by Medicare, but they have not fully announced that yet. I've had a range of responses. I've had some people whose insurance covered it even before, and I've had some people whose insurance didn't cover it. The test that I've been sending has been costing about $300. So it's not nothing. But compared to some of the brain scans that I'm going to talk about in a second, it's much, much, much cheaper to get those answers. It's a very good question. So a lot of challenges to using those blood tests, but it is an important step in the right direction. It's been a holy grail of, especially the Alzheimer's disease research world, to say if we can get a blood test that works well in lots of populations and we understand how it works, that's going to help us to diagnose people earlier and better. Okay, brain scans, another big important part of how we evaluate patients for dementia. And we're going to talk about two different types of brain scans. We're going to talk about structural brain scans, which are mostly MRI scans or CT scans in some cases. And we're going to talk a little bit about PET scans, which I've alluded to a little bit. So there's, again, a couple different reasons we might do the brain scans. The first reason, similar to the first reason we do the blood tests, is that we want to rule out unrecognized changes that might be more urgent that we'd want to know about right away. And so these things could be issues like brain tumors, and we could advance the slide, I think, one. Perfect. Thank you, Paula. So things like brain tumors, extra fluid in the brain, unrecognized or slow brain bleeds, right? So the number one reason I'm saying we should get an MRI or we should get a CAT scan is I want to make sure we're not missing some of these things that are better caught sooner rather than later, right? And the MRI scans really help us look for that. They're really good at that. The number two reason is I want to look for changes in the brain that could be related to blood vessel health, right? Things like past strokes or scars or damage to the brain that could result from things like high blood pressure, high cholesterol, diabetes or blood glucose problems, sleep apnea, smoking, right? These things that damage the blood vessels in our heart and our body also damage the blood vessels in our brain. They can lead to scarring, and in more moderate, severe cases, they can lead to thinking skill changes. Next slide, please. So those show up these bright white spots in the brain, right? Those are the scars I was talking about. And if you develop more and more of those scars, they can look like these larger patches. And it's probably different for everyone, but at some point that tips over to the point where there's too many scars and you start to show symptoms, that you show problems. And when that's the case, we call that vascular dementia or vascular cognitive impairment. That's where these things come from. Okay, so we're going to rule out unrecognized brain changes. We're going to look for vascular blood vessel problems. Number three is we're going to look, similarly, we're going to look for signs of neurodegenerative disease. In some cases, we can see areas of the brain that look like they've shrunk or they've lost brain cells as a result of the degeneration that happens in neurodegenerative disease. Typically, this, it might be in one small part of the brain, or it might be more generally. This can be hard to see, particularly in early cases, right? When the changes are microscopic, maybe the brain cells haven't fully died off, or maybe not all of them have. And so in early cases, a lot of times this might be normal. So it's not a great test for those early cases, but definitely if we see those changes, it helps tip our needle towards, yep, we're seeing signs that there's degeneration there. So here I have, and it might be a little difficult to see, but it's very asymmetric from one side of the brain where there's that red arrow on the right to the other side. You can see that side looks like it's shrunk in, and there's more space around it, and the other side looks more full. There's a couple areas we might look for. There's another example. There's an area of the brain called the hippocampus, which is really important for our memory circuits, and it tends to be hit very early in cases of Alzheimer's disease. And so we look at that and as a marker to say, do we see changes, shrinking, or change in the structure of that part of the brain that can help us, right, titrate our worry for Alzheimer's disease. Yes?
Can you see plaque?
Yeah, it's a very good question. The question was, can you see those plaques I was mentioning in MRI and CAT scans? The answer to that is no, you cannot. The MRI tells us about the overall global structure of the brain, but it doesn't tell us about what's going on microscopically. But we do have a solution to that, which I'm going to talk about in the next slide after this.
Okay, because the doctors are saying, or have said,
Yeah, so there is a brain scan that can help us look at plaque, and that's the PET scans that I alluded to, and we're going to talk about those in a second. That's a very good question. So with these MRI scans, we've started to come up with some new ways to try and find that shrinking or the changes using specialized computer programs to kind of map out areas of the brain and kind of measure what those things might look like and see how they compare to other people for that age. And we can just skip through the animation for this. Oop. Yeah, I'll keep going. Okay, so the MRI and the CAT scans, right, help us look for that unrecognized brain pathology, look at the structure of the brain, look for blood vessel or vascular changes. But PET scans can tell us more about microscopic or metabolic factors, and they work a little differently than MRI scans. PET scans help us there's different types of PET scans, but with any PET scan, the patient would have to get a special compound injected through an intravenous line, right, so into their blood circulation, and then that compound would circulate up and bind to whatever it binds to. And so in many cases, we use a PET scan called a glucose PET scan, which we inject a special form of sugar, and the brain cells love to eat sugar, so it circulates up, and we can see which brain cells are taking in more sugar and using more energy. This type of PET scan is called an amyloid PET scan. And I mentioned amyloid before as one of the proteins that builds up in the brain of people with Alzheimer's, and it leads to these plaques that we can see under the microscope when we take those parts of the brain and put them under a microscope. And those plaques are microscopic, right? We need the microscope to see them. We cannot see them on the MRI. But we now have compounds, tracer compounds, that we can inject into the bloodstream, and they circulate up to the brain, and they bind to those amyloid plaques, and then the PET scan can detect them. And so this is these have been around probably about, in more common use, probably about 5 to 10 years. But they've only recently been starting to get covered by Medicare and other insurance companies, so we've started to use them in our clinic within the last few years as well. Yes, ma'am.
Is that why they call it a blood test?
Say that again, I'm sorry.
Is that why the neurologist would have said to me a blood test showed up in his blood test?
So the question was how it is related to blood testing. Yeah. Sure. So that's a very good question. The blood test that I showed before that, phospho-tau 217, the way it was tested against this type of scan. So when the blood test was high, it correlated with having plaques on the scan. So I think that's probably what they meant. Yeah, that if the blood test was high, there's a good likelihood that there's plaques in the brain. Yep, I think that's correct. So this brain scan is another way we can look specifically for signs of Alzheimer's disease in the brain. It's been used as kind of the gold standard, and for some of the new Alzheimer's disease medications, these are one of the tests you have to do to prove they have amyloid plaque before you use anti-amyloid medications, which are those new medications. So this can be a powerful tool that we're starting to use now. These, without insurance, would cost probably about $10,000. $10,000 or several thousand at the very least. They're very expensive, which is why the blood test is something that, as researchers, as dementia specialists, we've been looking forward to because it's so much cheaper and it becomes so much available. These types of PET scans would only be available at places that have specialized radiology centers that can develop that compound and know how to use it properly. So they're important, I think, important parts of our testing regimen, but I don't send everyone for this test because of the cost, and it depends on the situation. So I mentioned there's lots of different types of PET scans, and I think we'll move towards a world where it might mean we do multiple types of brain images, right? People might get an MRI scan, they might get a PET scan, they might get 2 different types of PET scans. But there's on the left side here, I've got the MRI, that glucose PET I mentioned, and the amyloid PET. Those are things we're using right now in practice depending on the situation. And on the right side, we've got things that look for tau protein in the brain. Right? I mentioned that's the other protein that builds up in Alzheimer's disease. That has not made the jump into clinical practice yet, but I think it will in the next few years. And some other types of PET scans that help us look at the connections between nerve cells or signs of inflammation in the brain between those nerve cells. And those could have a role in helping us understand what are the components to any single person's dementia. Yes, ma'am.
So an undiagnosed psychiatric illness could cause dementia.
Correct. So the question was, could undiagnosed psychiatric illness lead to dementia? And the answer to that is a resounding yes. The old-timey name for schizophrenia, right, a thought disorder with psychosis, hallucinations, delusions, was dementia precox, is what, if you look 100 years ago, that's what the psychiatrists were calling it, because it led to dementia, but young, when they were early, which is that precox part of it. And so there's a lot of overlap there with how the brains are changing that we don't fully understand yet, but there's definitely kind of shared risk there in people who have very profound psychiatric disorders. Mm-hmm. All right. I have just a few more quick slides, and then I'm happy to answer a lot more questions. So those are the kind of main tests that we're thinking of, depending on the situation. And we can advance the slide, please, Paula. We might send some other tests if we're worried about signs of inflammation, or we're looking for a more confirmatory test for those Alzheimer's disease proteins. We might recommend someone get a spinal tap or a lumbar puncture to test the spinal fluid for signs of infection, inflammation, or those Alzheimer's disease proteins. If we're concerned someone might be having seizures or unexplained fluctuating events, we might do a brainwave recording, which we call an EEG. If we're concerned about someone's spinal cord or their muscles or the nerves in their arms or legs, we might have them do testing of their nerves and muscles with what we call an EMG, or nerve conduction studies. Okay, so I just want to go over our kind of 3 goals, right? We talked about defining dementia, what I mean when I use the term dementia, when a physician uses a mild cognitive impairment, and how we differentiate that from the causes of dementia, which I think is the more important question. Walking through what that initial neurology visit is like, what kinds of questions we're trying to get at, what kind of answers about figuring out those contributing factors, going through the physical exam, and then some of the kind of more common tests that we're thinking about, particularly the blood tests and the brain scans that we're using to help diagnose the causes of dementia. Okay, and I want to highlight again, right? Diagnosing dementia is not always straightforward. There's a lot of uncertainty, but the other thing I put on this slide is that it's a team sport, right? And it's a big team, and the first person on that team is going to be the patient, right? They're the ones running the show as long as they can. But the second person on that team is going to be their family, their caregivers, people who understand them. And if you could advance the slide, please, Paul. Yeah. It's a big team, right? There's a lot of people involved. The patient, the family, the caregivers, the friends, the community, the support system, the medical providers, the primary care doctors, the dementia specialists. That could be a neurologist, it could be a geriatrician, some psychiatrists who specialize in this. It's people who help us interpret the brain scans, people who help us interpret the cognitive testing. It's our social work teams, it's our other caregivers, it's our therapists, our physical, occupational, our speech therapists, right? It's a big, big, big team that we all need to help take care of people with dementia, help support them, keep them safe, and work through that uncertainty that can sometimes resolve. And we'll keep that in mind, right? Team sport, there's still a lot of uncertainty there, but we're getting better, right? We're getting better tests, we're getting more definitive ways to figure this out. Most cases of dementia are due to multiple things. Maybe a big primary thing, but then some secondary things along. And then the most important test that the neurologist is looking for is that story, is knowing what happened, when it happened, what kinds of things happened. So I have a little bit of a plug here for the Michigan Alzheimer's Disease Research Center. They do have a center here in Detroit at the UM Detroit Center. And they do all sorts of research into various causes of dementia, Alzheimer's disease, not just studies for patients, but studies for caregivers too, how we can best learn from caregivers, support caregivers. One of the big themes of the center, 2 of the big themes of the center actually, is making sure we're trying to recruit people from underrepresented populations, right? From the Black population, from the Hispanic population. I do some outreach work with our Arab American population in Dearborn, because they're also underrepresented in dementia work. And dementia happens to all of us. It's not a problem just for one part of our society. They also do some work on disclosure of information. from research, which I do think is really important. So if you're interested, please talk to me, look us up. There's always new studies coming through. There are studies that, like I said, center in Detroit, so you don't have to travel all the way to Ann Arbor to take part in all of the studies. I'm happy to take any questions. I thank you all for inviting me here. It's been a blast. Ma'am, in the back, you had a question, I'm sorry, before. Mm-hmm. Sure. Yeah, so the question was to comment on testing for syphilis as part of the evaluation. And syphilis is, the medical history of syphilis is fascinating because it's called the great imitator, that it can cause all sorts of problems in all sorts of parts of the body. And syphilis is kind of an atypical infection, sexually transmitted typically, that can spread to the brain and the nerves very easily. It can sometimes lay dormant for years and years and years and years and years and years before it starts to show problems in the brain or the nerves of the head particularly. And so it was a major cause of dementia, particularly before we had antibiotics, so early in the 20th century. And we've never fully eradicated it, and we know that it kind of comes in waves, that there are times when syphilis is more prevalent, less prevalent, and it's something we can treat, right? It responds very well to things like penicillin, right? The first antibiotic that was discovered. And so if it's something that we find, someone has risk factors for it, then there's a treatment for it that can make them better. And so depending on the risk factors, depending on where they've lived, what kinds of things they've been a part of, where they live currently, and what the rates of syphilis might be, I do end up sending screening tests for it. I can't say I see it very commonly. I've maybe seen 1 to 2 cases of neurosyphilis in the last 8 years, and one of those didn't cause cognitive issues. It caused mostly eye issues and nerve issues and then the rest of the body. But again, it's something that we can change, something we can treat, and it's a blood test that's cheap. And so it's definitely part of our thinking skills when we're saying this might be unlikely, but if we find it, it's really going to change what we do and change how this person might do. Yes, sir. Sure, that's it. So the question was, what is a silent stroke, and what are some of the causes or symptoms, or to talk a little bit more about that. Now, I'd shown an image of an MRI scan that showed those bright spots kind of deep in the brain, if you recall those. And those scars are akin to what we might call a silent stroke. So a stroke is when you lose blood flow to a part of the brain, typically very suddenly, and then it causes problems. Whatever part of the brain the stroke has happened in, that's the types of problems you see. So strokes that cause symptoms, we're seeing all of a sudden you have trouble moving one part of your body or using one part of your body or one half of your body. Now a silent stroke, we say, okay, we're worried that the blood vessels have been damaged and they've maybe lost blood flow, but it happened maybe in such a small way that we didn't see any symptoms from it. And those are sometimes picked up by those brain scans, that the MRI scans particularly, where we'll see an area of damage and we'll say, well, that looks like a stroke. It looks like an area where you maybe lost blood flow and that part of the brain died off. And then we talk to the patient and they say, well, I've never had anything like a stroke. I've never had a time when all of a sudden I couldn't talk or I couldn't see out one side or I couldn't move my arms or legs properly. And then we say, okay, well, maybe that was a silent stroke, that maybe it hit the part of your brain just so that other parts of your brain could take over and there's redundancy there. But it tells us that you're someone who's at risk to have damage to their blood vessels. That could cause damage to the brain. That could lead to thinking changes or dementia. So risk factors for that are the same things that cause risk factors for heart disease or stroke, right? High blood pressure, high cholesterol, high blood sugars, smoking, sleep apnea, right? Anything that can damage those blood vessels can damage the blood vessels in the brain. Yes, sir, in the back. Mm-hmm. Sure. So the question is distinguishing stroke from aneurysm. So a stroke is when you lose blood flow to a part of the brain, and there's kind of two main types. One is called when a blood clot or something else blocks the blood flow, and the other is when the blood vessels lead to bleeding, and we call that a hemorrhagic stroke, or when there's a large amount of blood in the brain. An aneurysm is when there's a weakening of the blood vessel so that it causes a bulge, and that bulge is the aneurysm. And those aneurysms are at risk to burst open and cause bleeding, which can lead to that hemorrhagic stroke. Yes, in the back with the hat, please. So very good, two good questions there. So the first is, what can we do to keep our brain healthy? And the second is, what age does dementia start? I'm going to take the second one first. So the age is variable, right? It depends on the cause, right? We said dementia is a big umbrella term, and there's a lot of different causes. So when we're thinking about neurodegenerative diseases like Alzheimer's, they tend to affect people as they get up into their late 60s, their 70s, their 80s. But there are younger onset forms of neurodegenerative disease as well. So there's no hard and fast rule that someone who's in their 50s can never have a dementia or neurodegenerative disease. Yeah, yes. So depending on the underlying issue, right, people who have liver problems in their 40s develop cognitive changes, they can develop dementia, right? People who have vitamin deficiencies, right? So depending on the underlying cause, it could happen across the lifespan. Because of neurodegenerative diseases and how big of a cause they are, we tend to see it more in older populations. So definitely getting into your 60s, your 70s, your 80s. The first question was, what can we do to keep our brains healthy? And this is a really, really, really important question, a really important thing. Exercise, I hear in the crowd, is the number one thing. So there's five basic things that I tend to talk to my patients about, so I'll go over them real briefly. 3 of them have to do with activity. Right? The first one is physical activity, is doing some kind of routine, regular exercise. And preferably something that gets your heart rate up a little bit, some aerobic exercise that's comfortable for you that you can do regularly. It could be going for a walk, it could be biking, it could be swimming, it could be, right, any of those things. It's not that you have to go out and run a marathon, but getting into doing something that's going to get your heart rate up a little bit. It's going to have good effects on your blood pressure, your mood, your sleep. Right? So the number one, if you take one thing away, that's the best thing you could do. Number 2 is mental activity. And this has been less studied. I do a little bit of work on this in my research, but I have 2 rules for mental activity. There's people who say, well, you have to do crosswords, right? And crosswords are great, but the first rule for mental activity is that you have to enjoy it. If you don't like doing crosswords, it's a waste of your time to sit around doing crosswords, right? You want to find something you enjoy doing. Number 2, it has to be something where you are making a decision and you are practicing those decision-making, problem-solving skills in a safe way, right? So if you like crosswords, those are great because you have an effect on what happens next. I have a lot of people come and say, well, I'm active, I watch TV and I like to read. And I say, well, you're not in charge of what happens on the television, right? You're not making the television show. You don't know you're not making those decisions. So it's different if you're saying I'm gonna do a study of the entire run of Happy Days, and I'm gonna analyze the right the way the every time a Fonz says something funny, right? So that being more active with your thinking. But games, puzzles, word games are a very common way people do that. In many cases, people do crafts, skills, hobbies. Could be something as simple as dancing, drawing, coloring, journaling, right? Something where you're making a decision and you have to enjoy it. So physical activity, mental activity. Number 3 is social activity, and that's being around people. That's exercising the social skills that your brain is good for, right? It's not being isolated. And that can be really hard, right? Especially the last few years with the pandemic and the changes in our society. It's really difficult, but it definitely makes a difference. With the lockdowns that happened in the pandemic, we saw people who had cognitive changes, were doing pretty well, and then they were cut off from their sources of support, from their social supports, and that's when they had a lot more problems. So we know that it makes a difference, and that can be really tricky. That's one of the hardest things we try and deal with. Say, how do we get people into these sort of community situations? 4 and 5, number 4 is mood, right? If we're dealing with significant anxiety, significant depression, significant trauma, I work with a lot of veterans who have a lot of post-traumatic stress disorder, right? These are things that can, like I said, they only make things worse. So we need to do what we can to help people manage those feelings, whether that's related to medications or non-medication ways. Those are things we want to pay close attention to. Number 5 is sleep. Right, sleep is really, really, really important. I'd probably reorder them and put exercise and then sleep as the two most important. We want to make sure people are getting good night's rest, that they're not having trouble falling asleep, that they're getting all the deep sleep they need for their brain to clear out all the gunk from the day. And so that's really important. Yes, ma'am. Mm-hmm. Yeah, so the question is how many people come on their own, or how many people are kind of pushed into coming by their family or their support system. I would say there's a mix. Probably, I'd say 60, 70% is the family is coming with them. I'm not necessarily asked all of them of like who initiated it. I definitely have patients who come to me on their own and said, I'm worried about this because of my family history, or because of the knowledge I have, and I'd like to get evaluated. And that's completely valid, completely reasonable, and I have a lot of patients like that. And I have some patients who it's kind of a joint thing. They're saying, I'm having some issues, my family started to know some issues, and we're both worried, and we're all going to come and chat, right, about it. And it's very helpful to have, like I said, the family member or friend or someone who knows the person well there. And I definitely have patients who they are fighting tooth and nail to not come and see me, for various reasons. Sometimes it's because they've progressed to the point where they don't recognize that they have these issues, and they don't understand the need for it. Sometimes it's more of the psychological, right? It's a scary thing. It's frightening. No one likes to go to the doctor. I try to make it pleasant, but no one likes to be there, right? And particularly when it's something that has to do with your mind and who you are, a core of a person, I can imagine how frightening that is. And so I can understand that they don't want to be there. And so sometimes there is that back and forth of maybe I'm talking more with a family member than I am with the person, but trying to get the information in any way we need. Yes, ma'am.
When she mentioned what she could do to keep her brain healthy, I had a fall, and when I had my fall, I ended up with a traumatic brain injury.
Oh, goodness.
And from the fall, after I fell and hit my head,
Mm-hmm.
I had a major stroke.
Oh, goodness.
At the time I fell. So now, 15 years later, I have my first two major diagnoses the traumatic brain injury with all the things that you just mentioned, the PTSD and all that other stuff.
Yeah.
Post-conscious disorder, and I'm a functioning paraplegic.
Gotcha.
So I have 40 to 60% of my brain doesn't have the tissue, so I don't get blood or oxygen in those areas.
Mm-hmm.
So what do you think? I know I'm not trying to ask medical advice, but I do the exercise. I try to get out as much as possible. I try to eat. Well, I'm a vegetarian now, or pescatarian.
Sure.
And I try to do everything I can. The reason why I'm not paralyzed up here anymore is because I started doing water aerobics, yoga, Pilates.
Sure.
I don't want to be in that severe pain and brittle anymore. So I make myself move.
Yeah.
But I know the prognosis is, well, they gave me 3 years to live in the beginning, but the prognosis is supposed to be I'll go to sleep one night and, so, but I'm trying, I do everything. They mentioned that oxygen thing a long time ago, before it got really popular, but I'm trying just to, is there more that I could be doing besides praying? Because God is doing everything.
Sure.
I'm not supposed to be, my GAF score is like really low, but you can't look at me and tell. And it says my brain doesn't pick up the right side of things and all this stuff, but my doctors, you can't tell.
Yeah, so I think the broader question here is about recovery, is about if you've had changes to your brain, what are the ways in which it could try to heal or help you adapt to it. And there's a lot of unknowns there in terms of how the brain works. It's some of what I work on is non-medication ways to see if we can help the brain function, particularly in degenerative dementias. But in the broader world of traumatic brain injury or stroke injury, that rehabilitation and helping people understand what they do is still a big topic as well.
They sent me in 2016 to get brain surgery from what the papers and their tests showed. We went there for my blood work prior to, and he wouldn't do anything because he thought I should have.
So,
I apologize.
yeah.
I love you dearly.
I know, I'm done.
What I'd like you to do is to touch our doctor afterwards,
Okay.
and that way you could probably spend a few more minutes on.
Sure.
a very
Yeah.
to your needs.
I don't want to comment on any medical advice, but I think the mindset of finding the things you can do and pursuing them to the best of your ability, that activity, the sleep, the mood, that perspective and that mindset, that plays a role in itself too, right? That's the people who keep going, who keep trying, that they do better.
Can I ask two questions?
Of course.
One, if I leave the doctor's office that's making an assessment after one visit, and they say, you have dementia, do I trust that, and they don't want to see me again? So they made a diagnosis in one session.
So the question is, if you see a doctor, physician, and they say you have dementia, you don't need to come back and see me. I would be a little worried about that. I try not to make too many diagnoses the first time someone comes to see me, right? I try not to say that someone has Alzheimer's disease for sure, right? I want to look at all the other pieces of the puzzle and see what kind of picture is coming out of that. And one of those pieces of the puzzle is that change over time. And one of the reasons that I'm there as a doctor is to help people. And so I don't want to cut people loose and send them off into the wind. I want them to come back and say, how are you doing? What's going on? What kinds of problems are we seeing? What are things we could try and help manage? And so, yes, there are times people come in and I say, you for sure, you have dementia. I'm worried about this. I'm worried about Alzheimer's. I'm worried about your vitamin B12. We're going to check some things. You're going to come back and see me. I think depending on the level of expertise of the person you're seeing, there might be different pressures in terms of, time or insurance or other things that we've touched on. But at least in a specialty clinic like my clinic or my colleagues at the university, that's not the model we've been following. And I think I've had feedback from patients that they find that much more helpful. I've had patients who told me they've had a lot of negative experiences in their dementia evaluation, and I'm always so disheartened to hear about those. But someone had mentioned the level of education and knowledge. It's not just for patients and caregivers, it's also for medical professionals, which is why I do, try to educate some of the geriatric trainees and do some talks to that in that space too. But yeah, it's a very good question, Paul.
Second one, I have seen you, I've learned something. What should I actually leave your office with? I mean, what would be the expectations moving forward?
Yeah, so the question is, once you've done the evaluation, what are the expectations moving forward? It depends a bit on the situation, right? People come at different times. Sometimes people are coming, they're very, very early, or they might not even be manifesting symptoms, but it's something they're worried about, they want to go through evaluation. Sometimes people come and see me and they might be in more moderate or later stages of dementia, and then the focus is on symptom management and support. And so it kind of depends on the situation. What I'd expect is if we're doing testing or treatments, that you are on board with those. If you have problems with them, I'd want you to ask. I'd want you to contact me or my colleagues, whoever you're seeing, and say, what was this for again? Why are we doing this? What's the plan for this? That's never the wrong thing to do. The wrong thing is saying, I don't remember what this is for, I'm not going to do it. I'm not going to talk to them. I'm not going to do it. Ask us. Get back in touch with us. Say, okay, they want to do a blood test, but I couldn't remember exactly what it was. We talked about it, but I'm not sure what it was. Can you tell me about it again? Come back to see us. Don't cut yourself loose. It's one thing if the doctor says, I don't want to see you again, which I don't think is maybe necessarily the right approach when we're dealing with dementia. But don't do that to yourself, right? Keep yourself in the mix, and get in touch with us if if you have a question, if you heard about something new or different, you should ask.
It is 1 o'clock. As much as can we take the last two?
We can do last two. Yeah, that's fine. Yes.
If you're going to a primary care doctor and you're diabetic, how often will the primary care doctor know to refer you to a doctor like yourself?
So the question is, will a primary care doctor know to refer you to a specialist when we're seeing those signs? They should, is what I'm hearing, but that's not always the case, right? And so again, that kind of self-advocacy of, what was that test for? What was that medication for? If this is something that you're concerned about, you're seeing the signs of in yourself or someone you care about, you can push them to say, I'd like a referral. It doesn't take up a lot of their time to refer you, right? But it might not necessarily be something that comes top of mind if they're thinking about all these other issues and all the other things they have to deal with, and saying, I'd like to see someone. Can you send a referral for me? Many places you can go that you can call in and say, do I even need a referral? Most of the people coming to our clinic will have a referral, but I think people are self-referred as well if they call into the clinic and to get an assessment. So yeah, so advocating for yourself can be a good part of that. And then there's one last question, I think.
As a scientist, are you more inclined to be agnostic? And secondly, is faith or one's inclination to be negative or a warrior? Or is attitude a factor?
Sure. Yeah. Yeah. So the question is how does attitude, how does faith play a role in these types of assessments? And I would say in my experience, not just as a dementia specialist, but as a doctor more generally, I would say that our beliefs, our mindset, our view on life, our perspective plays a big, big role in terms of how people do, how they respond to challenges, how they adapt to situations, what kind of social or other supports they have to kind of bolster them, right? And everyone's belief and perspective and faith can take different forms. But if the key question is there a role to have that sort of support and that sustenance? The answer is yes. I think that's a interesting philosophical topic that we could talk about at length for forever. I do not find those two things to be at odds with each other. Yeah.
How about we show some appreciation?
Yeah. Thank you. Oh yeah. No, thank you for having me. This is a lot of fun.
First of all, thank you so much for being here. And we have a resource. So those of you that have said to me, I'd like to see a neurologist or someone that will help with an assessment. We have a name, a connection, and I appreciate the straightforward answers that we've provided. I want to reinforce that we do a lunch and learn every month with some topic related to caregiving or dementia, that it's important that you come, join us, talk about issues, concerns, and we try to bring in experts on topics that will help us move forward. So our next topic, we're going to do something on grief, because that's important, because there's a loved one living with dementia or any loved one that has passed. We need to deal with how grief might be affecting us as the caregiver. Oh, I want to stress the thing that I heard here, as caregivers, you are essential to helping the doctors make an assessment. And I know many of you say, well, they don't listen to me. Well, you just find ways, get someone to coach you on how to say it, because sometimes we just may not say it as nicely as we could or should, or they're just not listening. But know that you have an important role. You're vital to the success of supporting your loved one, as well as getting information for yourself. So guys, thank you. We're live on Facebook, so we'll finish that and appreciate you. What we do now is we have a number of drawings, and many of the gifts have been given to us by caregivers and donations. that people have given to us, and we're going to just do some raffles for that. Also, in the back table, people bring supplies that they have extra things like Depends or lotions and keychains or things like that. Feel free to take any of that stuff that you want. Our way of trying to provide as many services as we can at once. And if you have things that you'd like to bring to share with other caregivers, please know we will be happy to take them and offer them up to other caregivers. So let's do this. Let me first say thank you to Sylvia. Everybody knows Sylvia, the most creative person I've met. Miss Sylvia, look up there. Sylvia's